Neurocognitive Disorders, recap of the PMHMP Review and Resource Manual, 4th edition, Chapter 12. Cognitive disorders are often thought of as disorders of older adults. Although most common in this population, cognitive disorders can occur at any age. Very young or very old people with cognitive disorders have multiple health needs. Older adults usually have more than one chronic illness, and psychiatric disorders can be accompanied by other comorbidities. Psychiatric mental health nurse practitioners must approach clients with cognitive disorders by conducting a multi-system assessment. Cognitive disorders cause a clinically significant deficit in cognition that represents a major change from the person's previous baseline level of functioning. There are two common disorders, delirium and dementia. The etiology, cognitive disorders are a complex general medical condition resulting in changes in multiple domains including memory, interpersonal relationships, and behavior. Cognitive disorders can result from injury, medical condition, substance use or abuse, a reaction to medications or ingested agents, or a combination of some or all of these factors. Delirium description is a syndrome and not a disease, with an acute onset that causes short-term changes in cognition. The hallmark symptom is a disturbance of consciousness accompanied by changes in cognition. Subtypes of delirium are hyperactive, where the person is agitated, restless, or hyperalert. And then there's hypoactive delirium, where the person is lethargic, slowed, apathetic. And there's mixed delirium, where the patient cycles between the hyperactive delirium and hypoactive delirium. Etiology is due to the changes in one of the following: general medical condition, substance-induced, or multiple physical health problems. Also, possible etiologies are medication, sleep deprivation, or other causes. The section of incidence and demographics is long, and I'm going to definitely recap that. So, incidence and demographics is common, especially in older adults, often overlooked and mistaken for other medical conditions or dementia. In persons with psychiatric disorders, it is often mistaken for worsening of psychotic symptoms instead of a distinct condition. The prevalence varies based on age and the client setting and sample. So, there's the highest risk in hospitalized older adults. 70 to 87% of older adults in the intensive care unit suffer from delirium, and 80% in terminal clients nearing death suffer from delirium. There's a poor prognosis, and 1-year mortality rate of clients with delirium is up to 40%. Risk factors for developing delirium is advanced age, multi-system medical illness. The more physically ill the client, the higher the risk, and substance abuse, visual or hearing impairment, and a past episode of delirium or pre-existing brain disorder or cognitive impairment. Prevention and screening. Use of the confusion assessment method instrument. What I have on the screen is the CAM-ICU, but it's the same. There's early recognition, intervention, and initiation of treatment. Whenever a client's clinical presentation changes rapidly from baseline, consider delirium as one of the possible differential diagnoses. Assess the following. Key findings for delirium are disturbance of consciousness develops over a short time, usually hours to days, and this disturbance tends to fluctuate during the day. Sleep-rest cycle disturbances, reversal of sleep-wake cycle is common. Clients are awake at night and sleep during the day. Impaired recent and intermittent memory. There's psychomotor agitation. The client exhibits purposeless random actions. The course of illness may resolve within hours to days. The more quickly the underlying physiological disturbance is recognized and treated, the more rapidly the delirium will resolve. Symptoms, when unrecognized, may persist for months. Most symptoms resolve within 3 to 6 months. Physical exam findings in delirium. Evidence that significant clinical symptoms are a consequence of direct physiological processes, substance use or abuse, or a general medical condition. Mental exam findings are general appearance is unconcerned for delirium, unconcerned with appearance, disheveled, and highly inattentive. The speech is usually impaired, disorganized, rambling, incoherent, or slurred. The affect is rapid, unpredictable shifts in affective state without known precipitation, lethargic, or agitated. The mood is difficult to elicit from the client. The thought process is disorganized, distractible. Perceptual disturbances could be illusions, which is the most common. So delirium, illusions, most common. Hallucinations are typically visual and accompanied by illusions. In delirium, hallucinations are typically visual and accompanied by illusions. Thought content is disorganized, distorted thought. Delusions and hallucinations are common. Disorientation is usually the first symptom to appear. The client usually is disoriented to time and place. Memory, there's impaired recent and immediate memory, and concentration is grossly impaired. Abstraction is grossly impaired, and judgment is grossly impaired as well. Diagnostic and laboratory findings for delirium its findings are consistent with underlying physiological etiology. Workup includes standard tests including blood chemistry, CBC, thyroid function, syphilis, HIV, urine analysis, chest x-ray, serum or urine drug screen, electroencephalogram or EEG abnormalities, generalized slowing of the EEG. It shows generalized slowing of the brain waves and generalized increased activity if delirium is related to alcohol withdrawal. So with delirium and the EEG, there's a generalized slowing, but there's a generalized increased activity if delirium is related to alcohol withdrawal. Differential diagnosis are dementia, substance intoxication or withdrawal, schizophrenia, schizophreniform disorder, mood disorders with psychotic features. Clinical management. Undertake treatment of underlying condition or disorder. Avoid the use of new medication whenever possible because using them can cloud the diagnostic picture. Pharmacological management is symptomatic treatment, agitation and psychotic symptoms, antipsychotic agents such as Haldol, atypical antipsychotic agents, or anxiolytic agents for insomnia. Non-pharmacological management is monitor for safety needs, determine the reality orientation frequently, pay attention to basic needs such as hydration and nutrition. The client should be neither sensory deprived nor overstimulated. It is helpful to have in the client's room familiar people, familiar pictures or decorations, a clock or calendar, and regular orientation to person, place, and time. General health considerations. Delirium is associated with high morbidity and mortality. High morbidity results from injury or its associated problems related to inactivity, such as pneumonia or hydration and nutritional deficits. Safety concerns exist. The mnemonic delirium are drugs, electrolyte abnormality, low oxygen, infection, reduced sensory input, intracranial, urinary or renal retention, and myocardial. Lifespan considerations with delirium. Children are especially susceptible related to immature brain development and often mistaken for uncooperative behavior. If a child is not soothed by common methods such as parental presence, then delirium is suspected. Most common in febrile states. Medications known to affect cognition in children are especially common with anticholinergic medications. Older adults, there's susceptibility related to the physiological changes of aging, and older men are more prone than older women to develop delirium for unknown reasons. Dementia is a group of disorders characterized by gradual development of multiple cognitive deficits, impaired executive functioning, global intellect with preservation of level of consciousness, impaired problem solving, organizational skills, obviously impaired organizational skills, and altered memory. Various forms of dementia share common symptoms but have different underlying pathology. Dementia of Alzheimer's type, or DAT, dementia of Alzheimer's type, is the most common. There's a gradual onset and a progressive decline without focal neurological deficits. The hallmark of Alzheimer's dementia is amyloid deposits and neurofibrillary tangles. Vascular dementia is the second most type of dementia, and it's formerly called multi-infarct dementia, primarily caused by cardiovascular disease and characterized by step-by-step declines, most common in men with pre-existing high blood pressure and cardiovascular risks. Hallmarks are carotid bruits, fundoscopic abnormalities, and enlarged cardiac chambers. Dementia due to HIV disease is classified as a subcortical dementia. Parenchymal abnormalities visualized on the MRI scan. HIV-associated neurocognitive disorder or HIV encephalopathy are severe forms. HIV can cause many psychiatric symptoms. Manifests by progressive cognitive decline, motor abnormalities, and behavioral abnormalities. It co-occurs with OCD, PTSD, generalized anxiety disorder, depression, and mania. Development of dementia in clients with HIV is an indicator of poor prognosis. Death usually occurs within 6 months. Psychotic symptoms usually occur in the late-stage infection. Clinical signs of late-stage HIV-related dementia include cognitive, motor, behavioral, and affective impairment, global cognitive impairment, mutism, seizures, hallucinations, delusions, apathy, and mania. Antiretrovirals and protease inhibitors can interact with psychotropic medications because many are metabolized by the P450 system or are CYP3A4 inhibitors or CYP3A4 inhibitors. Therefore, prescribing psychotropic medications in this client population should be done with caution while monitoring for drug interactions. Pick's disease, also known as frontotemporal dementia, there's neuronal loss, gliosis, and Pick's bodies present. It's more common in men, personality and behavioral changes in early stage, cognitive changes in later stages, and Clover-Bucy syndrome, which is hypersexuality, hyperorality, and placidity. Creutzfeldt-Jakob disease is a fatal and rapidly progressive disorder. It occurs mainly in adults in middle age or older. Initially, it manifests with fatigue, flu-like symptoms, cognitive impairment, but later manifests as aphasia, apraxia, emotional lability, depression, mania, psychosis, and marked personality changes, and dementia. Death usually occurs within 6 months of developing Creutzfeldt-Jakob disease. Huntington disease is a subcortical type of dementia characterized mostly by motor abnormalities, psychomotor slowing, and difficulty with complex tasks. Memory, language, and insight usually are intact until the late stages. There's a high incidence of depression and psychosis with Huntington's disease. Lewy body disease is caused by Lewy inclusion bodies in the cortex. It presents with recurrent visual hallucinations, and Parkinson features such as bradykinesia, cogwheel rigidity, and tremors. It adversely reacts to antipsychotics. For the etiology, there are multiple theories ranging from psychological to neurobiological. Probable multifactorial etiological profile. Primary cause is mostly unknown. General medical condition, result of substance use or abuse, reaction to medications or other ingested agents, or combination of some or all of these factors. Diffuse cerebral atrophy and enlarged ventricles in dementia of Alzheimer's type, and decreased acetylcholine and norepinephrine in dementia of Alzheimer's type. Genetic loading. There's genes on chromosomes 1, 14, and 21 have been identified in families with a history of dementia of Alzheimer's type. It's an autosomal dominant trait, and it's inherited alleles for APOE4 protein on chromosome 19 and are suspected to be related to late onset dementia. Incidence and demographics. often misdiagnosed or unrecognized, especially in early stages and in young clients. Prevalence is 1.6 for people in the United States over the age of 65 and 16 to 25% in people over the age of 85. Dementia of Alzheimer's type is the most common. It affects an estimated 4 million in the United States, and the duration of illness averages between 8 to 10 years. Dementia risk factors are age, multi-system medical illnesses, genetic loading, family history of dementia in first-order relatives, or history of substance use or abuse. Prevention and screening, early recognition, intervention, and initiation of treatment allows for ruling out related memory changes or unidentified conditions. Cognitive and functional evaluation at least every 3 years for people ages 65 or older. Baseline and regular cognitive evaluation to monitor cognitive decline and treatment response to medications in persons diagnosed with dementia. The U.S. Preventative Services Task Force concluded that there is insufficient evidence to determine if the benefits of routine screening outweigh the harms. And that's something from 2014. Assessment for dementia. Assess the following: a detailed history of present illness, time frame, progression, associated symptoms, past medical history, psychiatric history of depression, anxiety, and schizophrenia. The initial and periodic functional history and assessment, validate history with family or caregiver, memory impairment, immediate and intermediate, most prominent feature of the disorder, usually the earliest symptom. And I'll repeat that. Memory impairment, immediate and intermediate, is the most prominent feature of the disorder, usually the earliest symptom. Part of the previous slide is produces multiple deficits in daily functioning, unable to learn new information, forgets past information, loses valuables, forgets daily activities such as eating and dressing, and becomes easily lost, or has other cognitive deficits such as impaired executive functioning. This slide is instruments for assessing level of impairment. This might be a typo, but it says not in the public domain is the mini mental status exam. I believe that is in the public domain. And it's under the title of in public domain is the MOCA, which I know is proprietary, so I think that's not in the public domain. Anyway, that's backwards. I thought I'd mention that. So the MOCA is listed under in the public domain, which, yeah. Anyway, and the mini cognitive exam and the St. Louis University mental statics exam. I believe those are all proprietary, meaning that they're not in the public domain. That's just my thought. Anyway, remember to always consider visual, sensory, language, and physical disabilities as well as education when administering the mental status tests. Physical exam findings. Amaurosis fugax. It's a unilateral transient vision loss described as curtain over the eye, unilateral focal motor weakness, and asymmetrical reflexes. Mental statics exam findings. The general appearance is apraxia, decreased self-care activities of daily living. The speech is deterioration of language skills, aphasia, indefinite object recognition such as calling items, things, and being unable to find the discrete name. In advanced stages, there could be mutism or echolalia. For affect, there could be lability, and mood could be depressed, often difficult to elicit from the client what the actual mood is. The thought process is agnosia, and the thought content is difficult to elicit from the client. Orientation is disoriented to time and place, disoriented to person in the late stages of the disorder. For memory, there's impaired in many dimensions of memory, including word registration, recall, retention, and recognition. For concentration, the patient is distractible, the abstraction is concrete on proverb testing, and the judgment is grossly impaired for self and social judgment. Diagnostic and laboratory findings: CBC, chem profile, thyroid function test, B12, folate, to rule out metabolic causes or undefined conditions. Syphilis, drug toxicity screening if indicated by history. Alcohol and illicit drug screen if suspected or indicated. UA if there's a urinary tract infection is suspected. Arterial oxygen or pulse ox if hypoxemia is suspected. A CT or magnetic resonance imaging, or CT or MRI, are not routinely used for dementia. EEG is not useful, and neuropsychological testing is recommended to complete a diagnostic assessment. Differential diagnoses that are non-psychiatric could be Parkinson's disease, hearing loss, B12 and folate deficiencies, trauma, especially with a history of falls, hypothyroidism, infection, CVA, polypharmacy, or alcohol intoxication. Psychiatric differential diagnoses are mood disorders, delirium, and anxiety. For clinical management, general considerations are to rule out or treat any conditions that may contribute to cognitive impairment, discontinue unnecessary medications, especially sedatives and hypnotics. Pharmacological management of cognitive symptoms. There's NMDA receptor antagonists. The goal is to prevent overexcitation of the glutamate receptors and stabilize the neurodegenerative process. Memantine or Namenda is usually dosed at 10 to 20 milligrams twice a day. It's used for moderate to severe Alzheimer's dementia. It may slow the degenerative process. It promotes synaptic plasticity, and it may be used in combination with cholinesterase inhibitors. There's memantine and donazepam combination, which is called Nimzaric. It's a combination medication. Cholinesterase inhibitors may be initiated for mild to moderate dementia disease. That's cholinesterase inhibitors. They can lead to modest clinical improvement in some clients, with studies showing 2 to 3 point improvement in the MSC exam testing. Treat only symptoms, slow loss of function, and may improve agitated behaviors, but they do not prevent pathological progression of the actual disease, and they're not effective in severe end-stage disease, and they should stop if side effects, usually nausea and vomiting, are developed. Commonly used agents are donazepam, which is Aricept, at the usual dose of 5 to 10 milligrams a day. It's approved for mild, moderate, and severe Alzheimer's disease. There could be nausea, diarrhea, vomiting, appetite, weight loss, abnormal dreams, and insomnia when using donepezil or Aricept. Then there's rivastigmine tartrate, which is Exelon. Rivastigmine tartrate, which is Exelon. It's a 1.5 to 6 milligrams twice a day, and increase gradually to avoid nausea. It's indicated for mild to moderate Alzheimer's disease and Parkinson's disease dementia. There is rivastigmine transdermal patch that is 4.5, 9.5, or 13.3 milligram patch that is changed every 24 hours. I know we changed the site. There's so much more to know, but this is what the book talks about. So anyway, reiterate if a lapse in treatment occurs. Psychosis and agitation. Try non-pharmacological therapies first. Use antipsychotic agents for agitation or psychotic symptoms regularly. Use lowest effective dose and attempt to wean periodically. That is with psychosis and agitation and the use of antipsychotics. Antipsychotics may cause many side effects of significance in the older adult. There's EPS, sedation, postural hypotension, anticholinergic side effects. Benzodiazepines may be used for treating anxiety or infrequent agitation. Depression. Treat clients with depressive symptoms such as depressed mood, insomnia, fatigue, irritability, and appetite loss. Use the lowest effective dose, treat for 6 to 12 months, and then attempt to taper. Depression may reoccur and need to be treated as a chronic condition. Clients may have less depression as the dementia progresses and they become less aware of their circumstances. Non-pharmacological management. Educate the client and family about the illness, treatment, and community resources. Assist with long-term planning, including financial, legal, and advance directives. Assess home and driving safety. Use behavioral therapy to identify causes of problem behaviors and changes to the environment to reduce the behavior. Use recreational therapy, art, and pet therapy to reduce agitation and promote normalized behavior. Use reminiscence therapy or life review to to process through any unresolved issues and recollect the past. Maintain a simple daily routine for bathing, dressing, eating, toileting, and bedtime. Integrate cultural beliefs into the management of all clients with dementia. Psychotherapeutic approaches for HIV-related dementia are major psychodynamic themes for people with HIV-related dementia are issues of guilt, self-esteem, and fear of dying. Because the client may not be able to give a complete and accurate history, family or friends should be questioned about any unusual behavior or mental status changes. Changes in the level of activity, in interest in other people, or in personality are clues to an acute CNS disturbance. Some changes are directly due to brain dysfunction, while other changes are due to physiological distress or systemic problem, anxiety that the person is dying. The spectrum of neuropsychiatric and neurological manifestation depends on the severity of the immunosuppression. Psychiatric disorders may pre-exist or result from HIV. Even subtle neurocognitive impairment can affect physiological coping. Neuropsychiatric disorders are much more prevalent in late-stage illness. Lifespan considerations. Primarily a disease of older adults but can occur in children. Diagnosis is based on impaired cognition. The diagnosis is not applicable until ages of 4 to 6 years old when cognition can be fully assessed. So, delirium cannot be diagnosed in children until the ages of 4 to 6 years old when cognition can be fully assessed. Dementia in children usually presents as a deterioration in functioning, such as school performance or a delay in normal development. Major or minor neurocognitive disorder due to traumatic brain injury. Description. DSM-5 diagnostic criteria are met for a major or a minor neurocognitive disorder. Evidence of a traumatic brain injury, an impact to the head or other mechanism of rapid movement or displacement of the brain within the skull, with one or more of the following: loss of consciousness, PTS, post-traumatic amnesia, disorientation and confusion. Neurological signs are neuroimaging demonstrating an injury, new onset of seizures, worsening seizure disorder, visual field cuts, hemiparesis, anosmia, and then the neurocognitive disorder presents immediately after the occurrence of the traumatic brain injury or immediately after recovery of consciousness and persists past the acute post-injury period. The etiology: brain injury resulting when the head is hit or violently shaken, such as from a blast or explosion. The incidence and demographics: about 2% of the population and estimated 30% of returning soldiers. Risk factors are combat duty, exposing personnel to improvised explosive devices or IEDs, and used by opposing factions. Prevention and screening for military personnel. Mandatory post-deployment screening for all veterans returning from combat assignment. Traumatic brain injury screening are exposure to events such as blasts, vehicle accidents, and falls, and that may have caused brain injury. Immediate symptoms are such as loss of consciousness, feeling dazed, head injury, amnesia of the event. Onset or worsening of problems such as with memory, balance, headaches, dizziness, irritability, sensitivity to bright light, sleep problems that may indicate a brain injury. A continuation of the prevention and screening for military personnel. So, presence of symptoms in the past week. 4 factors complicate recovery from combat-related concussions compared with mild TBI acquired in civilian settings. The physically and emotionally traumatic environment in which they occur. The potentially repetitive and cumulative nature of concussions sustained over a tour or multiple tours of combat duty. The high incidence of comorbid mental health conditions and the difficulty in following typical recommendations of post-concussion care, such as rest. Mild TBI symptoms are mental status changes, poor concentration, depression, irritability, sensitivity to light, extreme fatigue, and acute symptoms of mild TBI could be dazed and confused. Moderate symptoms of TBI are chronic worsening headaches, repeated nausea and vomiting, seizures difficult to arouse from sleep, slurred speech, unequal pupils, confusion, restlessness, agitation, extreme weakness or numbness, and loss of coordination. So under mild TBI, it says extreme fatigue. So the word extreme is there, but it's still a mild TBI sign, but extreme weakness, which is different than fatigue, I guess. So extreme weakness or numbness, and that would be indicative of a moderate to severe TBI. The assessment for TBI-related dementia is physical findings and mental status exams. So there's a risk for suicide. Factors increasing the risk for suicide attempts with a TBI are males, ages 18 to 19, psychiatric disorder, aggressive behavior, or substance use. Diagnostic and laboratory findings for TBI-associated dementia is there are no current diagnostic tests that can retrospectively diagnose a mild TBI or determine that current symptoms or problems are due to a past mild TBI. Conventional structural neuroimaging studies are typically normal in mild TBI. A differential diagnosis for dementia-related TBI-related dementia is PTSD, depression, anxiety, and other mental health diagnosis. For clinical management and pharmacological management, there's no specific medications for TBI. Treat related symptoms according to current evidence-based standards. Increased sensitivity to side effects of medication is secondary to the head injury. There could be sedation, anticholinergic side effects. They decrease memory. Seizures with tricyclic antidepressants, bupropion, and amantadine. They all lower the seizure threshold. Extrapyramidal symptoms such as NMS and TD are higher. There's a higher risk for that in TBI-related dementia. And neuroleptics, they decrease neuronal recovery. Benzodiazepines decrease memory, increase confusion, decrease coordination, and there's always the abuse potential. Cognitive disorder recommendations are methylphenidate, which increases attention, processing speed, general cognitive function, learning, and memory. Dextromethamphetamine is increased attention, processing, and speed. Bromocriptine, off-label, possibly helpful to increase executive function. Amantadine, off-label, possibly helpful to increase general cognitive function, attention, and concentration. When using medications, start low and go slow. Non-pharmacological management. Treat comorbidities. Military personnel with TBI frequently have PTSD, which makes treatment of TBI more difficult. Safety plan for suicide risk. Limit availability of means. Teach family to identify signs of risk for suicide. Follow up 1 year after anyone with TBI makes a suicide attempt. Follow up to 1 year. Treat vestibular dysfunction with physical therapy to reduce dizziness, and treat traumatic vision syndrome with occupational therapy. Scanning and accommodation difficulties lead to headaches, irritability, and fatigue. Treat memory impairment with occupational therapy to teach memory improvement skills. Teach about symptoms and implications for relationships, employment, etc. Avoid alcohol and neuropsychological testing. Also, we could recommend psychotherapy, supportive CBT to increase understanding of relationships between cognition and emotion, target adjustment or development or new beliefs and assumptions. Also, we could recommend behavioral therapy or family therapy. Behavioral, affective, and personality changes are most difficult for families to adjust to. And I just spoke about psychotherapy. Tips for families are: if concentration is an issue, ask the TBI survivor for one thing at a time. Use of white noise machine may reduce distractions. They may take longer to complete tasks. If memory is an issue, keep a notepad near the phone for messages and in other places throughout the house. Keep a memory book. Make a calendar and keep the calendar in a central location. If anger or irritability is an issue, leave the situation if possible and wait for the TBI survivor to calm down. Use a soft, calm voice and keep your distance and give the TBI survivor space. The resources are Defense and Veterans Brain Injury Center, that's dvbic.org, Brain Injury Association of America, that's biausa.org, and the U.S. Department of Veteran Affairs, va.gov. Cognitive impairment and associated core features of cognitive behavioral therapy. So the cognitive impairment of impulsivity, the core feature of CBT is to teach them to stop, think, and reflect. The cognitive impairment of decreased awareness and encoding and recall, the core feature of CBT to employ is monitoring problems and successes. For memory, we would use the CBT feature of use of audio tapes of sessions, that's for memory, and executive function impairment would, the core CBT therapy modality would be to develop independent problem solving for everyday difficulties. Tips for the PMHMP for therapy with a client with TBI is to determine what having a TBI means to the client. Focus on real-life difficulties in the here and now. Monitor speed and complexity of comments. Adjust the session length according to the level of attention and fatigue. Reestablish an acceptable sense of self. Instill hope without making predictions of a successful rehabilitation outcome. Lifespan considerations. For mild TBI, most clients achieve full recovery within 3 months. If residual symptoms continue, then there's 80 to 85% will clear within 6 months, and that is for mild TBIs. For follow-up, symptoms may occur immediately but may also appear much later, which underscores the importance of screening for TBI. This concludes the neurocognitive disorder chapter, and up next would have been the substance use disorder, but I already completed that chapter. So this moves us forward, or I guess myself forward, to chapter 14, which is personality disorders, and that should be tackled tomorrow.